to the Fracture Files, the silver linings of geriatric fractures and fracture care. My name is Megan Sorich. I am a orthopedic surgeon that specializes in geriatric fracture care, and I work at UT Southwestern in Dallas, Texas. With me today, I have Carmen Quatman.
Hi, good morning. I'm Carmen Quatman. I'm also an orthopedic surgeon, traumatologist, and I focus on geriatrics as well. I'm also a surgeon scientist, and a lot of my research focuses on how to help our patients succeed after hip fracture surgery. And I think that's going to be our topic today. I'm from The Ohio State University as well.
So yeah, as Dr. Quatman was saying, today we're going to talk about the first 7 days of hip fracture. And these are arguably the most important days that kind of sets the patient's course for their success and outcomes of recovering after hip fracture.
Yeah, that's such a critical time. I think it's a time of difficulty, not only for the patient, but for the entire family as they start to explore what is occurring. Hip fractures are really interesting. They have a unique presentation timeline. Sometimes we see them within a few hours, and sometimes we see them a couple days afterwards, even that they've been transferred from other facilities, or worst case scenario, they've been found down after several days, kind of on the floor, and severe trauma, presentation. But Dr. Sorich, what's your kind of experience in that first, 24-hour window?
Yeah, so similar to you, we take care of a very sick patient population. So we do take in a lot of transfers that you're right. They can be either found down or even at an outside facility for days before we're alerted about this patient. And as our literature shows, that first 24 hours to 48 hours are the most critical time for fracture care. In trauma, they talk about the golden hour, which is the first 90 minutes of really assessing the patient and really managing the patient. And in hip fractures, that kind of equivalates to that first 24 hours. So ideally, we want to get the patient to surgery and get them fixed within that 24 to 48 hours. And sometimes that's not always possible, which creates a hard situation.
Yeah, I think that's really important to really think about. And the golden hour, I think, still really does apply in many of these patients. They're very, very under resuscitated. So many are dehydrated. The hip fracture is sometimes a symptom of a much bigger thing that's going on with them. And so we don't get to start from even a trauma window. We're actually talking with patients who may not have been at their optimal health at the moment of injury. And so we really have to almost take a step back and try to acknowledge where they are, where we need to get them to be. I sometimes equate it to like getting them ready for a marathon. So we have to really think about where they stand and if they're ready to endure the surgery. What are their wishes? And one of the hardest things that I see in this patient population is if they have any cognitive impairments, it can be really difficult to not only know what their wishes were, but to get consent. Do you have any challenges with that you guys face?
Yeah, absolutely. And one thing within that is sometimes this is the first time that the family kind of all gets together to say, hey, what was mom or dad's wishes? Do they want to get this fixed? What does kind of end of life care? And we start having these difficult discussions, usually in these unplanned events like hip fractures. So it's we do a lot of goals of care or family meetings with our geriatric medicine team to kind of start some of those conversations that maybe families haven't thought about before.
Yeah, I think that's actually really important. And one of the hardest things is they think we're rushing into surgery when maybe they've already had some plans to have, more palliative experiences. And that can be a really challenging conversation because personally, I think most hip fractures should be fixed, even for palliation, meaning that it's so painful to turn in bed, to do any basic basic needs to prevent pressure sores and pneumonia. Just that small motion is so painful. So it's a really hard conversation on a really fast track timeline sometimes, and can feel, I think, very scary for patients and their families.
Definitely. And I kind of echo your sentiments with that. I teach our residents that we fix hip fractures for two reasons, for pain control and mobility. And mobility is different for everybody. Mobility might just be sitting up in bed, sitting up in a chair, standing for transfers, and especially pain control. I feel like sometimes family doesn't always recognize that patients can't necessarily lay in bed and not move. So even for hygiene care, rolling and turning, those hip fractures can be exquisitely painful. Absolutely.
Mhm. Yeah, let's take a step back and talk about the different hip fracture treatments for a second for those who are not familiar, because I think that that's one of the misconceptions too. We have a lot of options for how we fix the hip fractures, and it really depends on the type of injury that we see. And a lot of things kind of go into that quote unquote hip fracture bucket. But do you want to talk a little bit about some of the decision making around what we do?
Sure. First of all, when we're talking about hip fractures, the hip is a ball and socket joint. So we are usually talking about the ball or the upper part of the thigh bone, or the femur bone. Sometimes hip fractures, when we talk about it gets confusing because it's about semantics. What we're not talking about is the socket part of the hip. We're not talking about pelvis fractures, acetabular fractures, which is the socket part of the hip. What we're talking about is the ball. So when we're talking about hip fractures, I make the analogy that a hip fracture is similar to an ice cream. It comes in a lot of flavors, and usually we're talking about where is the scoop of ice cream relative to the cone, or where's the ball sitting to the upper part of the femur bone. So there's three large categories of hip fractures when we're talking about femoral neck fractures, or fractures that are just below the ball, intertrochanteric femur fractures, or fractures that are just below that, kind of on the upper part of the thigh bone, and then subtrochanteric femur fractures, fractures that are even lower than that, but still on the upper portion of that thigh bone.
Yeah, that's great points. And I like to emphasize for all that are not necessarily orthopedic surgeons is that the procedure that we choose based on the type of fracture we see, and sometimes based on the patient's expected course, can be very different. So sometimes we're just putting a couple of screws across, and sometimes we're going in and doing a whole hip replacement. And what's necessary to survive those surgeries or to thrive after those surgeries is really dependent on the patient, on presentation. But also, we really don't have a great predictor for how patients are going to do. I've had patients who I think aren't going to be able to endure a really long surgery. We've even tried the non-operative route and they're not doing well. And then all of a sudden, they just realize that they would, choosing a high-risk surgery still is the right answer for them. And they do amazing sometimes. But on the flip side, we have patients that we just can't predict for how they're going to do. It's a major stress to go through surgery. And while I would love to choose like percutaneous pinning every time and let them get up and walk, it's not the right surgery. And so I spend a lot of time explaining to the patients why we're choosing what we're doing. Also, sometimes emphasizing even to the medicine and anesthesia teams why we're doing a certain procedure, because ideally we want the best outcome for the patient, and that can really be dictated by both the fracture and what the patient presents with from their comorbidity standpoint.
Definitely. And just to add to that, it's besides getting through the surgery and having the patient kind of succeed through surgery, it's also that perioperative course. Um, our goal is not to do a great surgery and patients not walk again. So even talking to the family about what does mom or dad look like after surgery? What are the expectations? What are we hoping for in terms of medically as well as surgery post-operatively?
Yeah. So let's talk a little bit about, like, so we tanked them up for surgery, meaning we got them all ready. We got maybe blood products on board if they needed a blood transfusion. We got their IV fluid and their kind of hydration status backed up through what we call resuscitation efforts. They haven't eaten or drinking anything, so we can take them safely to surgery. Now what?
Yeah, so we use an ERAS model that stands for Enhanced Recovery After Surgery. So we actually allow patients to have clear liquids up until about 2 hours before, similar to your marathon analogy. These patients sometimes are very dehydrated and aren't allowed to eat or drink for a long period of time. So within that, they can have clear liquids up until about 2 hours before surgery, nothing to eat for 8 hours prior to surgery. And then we focus on kind of their post-operative course preoperatively. So by that, we use regional anesthesia, so like a pain block, and then even decide with our anesthesia colleagues, what's the right anesthesia for this patient? Is it like a spinal anesthesia where medicine goes in your back so you can't feel your legs with some light sedation? Is it general anesthesia where you have a breathing tube and you're asleep the whole time? What can we do to minimize some delirium or kind of perioperative delirium after surgery?
Mhm. Yeah, that's great. We also try to lean into the ERAS model as well. And that starts from the minute they show up, and including the type of pre pain control things we can do, and or nausea and minimizing of any type of cognitive impairment type medications. So great. Surgery went great. We're doing great. Everything's ready. What are you going to tell the family?
Yeah, so talk to the family about at this point after surgery, the family's job is to be a cheerleader. So I want them to encourage the patient just to try their best with physical therapy, to encourage them to try to get out of bed for all their meals. We will attempt to manage the pain the best we can with those regional options, kind of multimodal, which means different types of pain medicine to try to prevent some delirium. But I just want the family to know that they need to encourage mom and dad just to do their best after surgery.
I love that. I would say the exact same thing. I basically talk about them being cheerleaders and that they really need a support system around them that's going to help them emotionally know that they're going to do okay. And it starts, and I also often emphasize, like, I know it seems like we're pushing mom or dad really hard and really fast, and that they just had a big surgery. But what we know about the outcomes for this is that it's really important that we start this from the minute they get out of surgery, trying to focus on nutrition and making sure they're attempting to get out of bed and get their confidence back, because we really want them to have the best outcome. And so while we're not trying to, I even say the word torture, we really are emphasizing this because we know it matters. And I am so happy when I see the family get engaged at that level. But
Yeah, and I also encourage the family to, if possible, stay with mom or dad while they're in a hospital. Sometimes the hospital environment is confusing, and a lot of literature shows that by having a family member or somebody with them, it can reduce that perioperative delirium.
Totally agree. And it doesn't just, end with the family. It's also encouraging the nursing team, all the PCAs on the floor to really kind of embrace that model as well.
Another thing that we talk about before surgery, and kind of throughout that hospital course is constipation prevention. So our older folks tend to get constipated, and then we give some pain medicine, then we add some anesthesia. And we're seeing that constipation really can lead to some delirium. So we're also trying to be pretty aggressive with a bowel regimen as well.
Yeah, that's important. And I think, like, so I kind of feel like days 2 through 3, 4 are really about helping the patient get confident about moving out of surgery, kind of dealing with any medical issues, but also kind of pre-planning the next step. And that starts with the conversations, sometimes even before surgery, about, okay, were they living independently? Do we think that's going to be the safe environment for them next step? Or are we going to have to come up with a different plan? And, I think the literature says about 80% often end up in a nursing facility, at least for a short term. Many people need support though. And so I think that that's so important if they do have an engaged support system, is making sure that they are aware of what the next step will be so that it doesn't feel like a surprise. And that sometimes is something as simple as having someone watch how we help them mobilize out of bed, talk about what their home environment is like and what we might need to make in terms of adjustments. Lots of really important strategies there.
Exactly. And I think this is something where kind of getting the family engaged, because more often than not, mom and dad not only live by themselves, or they take care of their spouse who's dependent on them. So this is not only a big change for them, the family, but also the person that they're providing care for. So it is a lot of planning that goes into this to create success kind of moving forward for the family as well as the patient.
Right, totally. And do you guys use a co-management system? I know there's a lot of, literature out there supporting this idea of co-management with both a surgical team and a medicine team.
Yeah, so our co-management program is called Restore, which stands for Returning Seniors to Orthopedic Excellence. And it's pretty fun. Medicine admits all of our patients. Orthopedics is always the consult, and then we get geriatric medicine on board as consults as well. We have nutrition, physical therapy, occupational therapy, social work, all seeing the patient with the common goal. All of our patients get admitted to our ACE unit, which stands for Acute Care of the Elderly, or a geriatrics unit. Um, and since we've launched, I guess 3 years ago now, we've seen a lot of positive outcomes, reducing mortality, and really a lot of great success for our hip fracture patients.
Yeah, that's awesome. We have something we call HOPS, and I honestly can't remember what it stands for, but it's hospitalists and orthopedics kind of co-managing together, where we focus on getting them ready for the next stage. And then once we're getting them ready to leave the hospital, we have something we call Ortho Connect, which basically allows us to look at that transition from inpatient to the outpatient setting. What's so important is we think of hip surgery as like a 1 day thing. The hospital stay is 5 to 7 days, but honestly, the recovery is up to a year. And so really finding ways to reconnect with the patients and make sure that they're safely transitioning and reassuring them along the journey. So what does that transition look like for you guys?
So we struggle a little bit with discharge planning. We have an inpatient rehab facility associated with the university, and everybody wants to go there. Um, and as we know, not all hip fracture patients are eligible for inpatient rehab. It's pretty stringent. It's 3 hours of pretty rigorous activity. So sometimes discharge planning for us is challenging. People say, "Oh, well, I want to stay at the university, so we want to go to inpatient rehab," and they feel disappointed if they end up going to a skilled nursing facility. So that's a transition that we're still kind of working with. We're trying to partner with some of the skilled nursing facilities to create less of a disappointment. But that's something that is challenging.
Couldn't agree more. And setting expectations and understanding what their goals are really, really important. And I think that there's a challenge in that gap, right? So even if they go to a one place, they end up having to get home eventually, and getting home eventually also still needs that kind of plan in place. And I'm not sure how well that happens at different institutions. So we try to take a little ownership of that while they're in the hospital.
Yeah, and same thing if they go to a facility and they don't like the facility, how to get to a different facility. Again, some of these things are challenging. And especially in our facilities, help is challenging. Maybe they're understaffed. And that's hard. And I make the analogy that everybody wants to go home. Home is best. So creating those goals, those expectations to get back home safely is everybody's goal, but again, we want to do it safely.
Yeah. So like we're running out of time here, but I want to touch on the length of stay. That's a metric that is so frustrating to me because I feel like that metric isn't an automatic number. We can't target exactly this amount of time. There's so much complexity that goes into that. Yet insurance companies and metricing systems are using length of stay as a criteria. How do you feel about that?
I too get very frustrated about this because I make the analogy it's never just a hip fracture. We take care of a large transplant patient population. Um, that are very quite ill. So their length of stay is going to look very different than my friends that fell walking to church. So again, every patient is so different that it's hard to say that the average length of stay should be fill in the blank. Everybody's hospital course is so different. And as much as we try to create these protocols to streamline care, we want the best care for every hip fracture patient. So I agree. I get very frustrated with length of stay and trying to quote kick people out of the hospital. We're not trying to do that. We want to get them to transition out of the hospital safely and really successfully.
Yeah. And sometimes that starts with literally the minute they hit the floor. One of the things that holds us up to getting to the next stage even is really planning ahead to know, where did they come from? Where are they going? And we have some policies in place, like they have to be seen by physical therapy before we can even start what's called a pre-cert to get them into the nursing
Same.
facility. And so one of the things we've done upstream is we make sure that we almost have like a high alert button that our physical therapists are alerted right away,
Yeah,
so
we
that
do
we
that
can get that
too.
going even before the OR.
Yeah, same. We do that too. And traditionally, patients get one round of physical therapy. But all of our hip fracture patients get 2 rounds of physical therapy every day. Just because we know the day after surgery, sometimes we get a little bit blood pressure issues, or we don't feel like moving as much and we don't get a great assessment. So we lose that whole day. So by seeing patients multiple times, that kind of gives us that assessment to kind of start that insurance ball rolling, if that makes sense.
Yeah, that's great. It's really critical. So I guess to kind of put it in summary, what do the first 7 days mean to you after a hip fracture?
First 7 days are pivotal. So this guarantees kind of the success or kind of the future of the patient. So we want our goals for the first 7 days is early operative management safely. We want patients to get up and moving as soon as they can after surgery. We want to really optimize nutrition and set the patient up and family for success, not only for getting discharged, but discharged safely. I could spend hours talking about the first 7 days because I think it's the most important part of hip fracture care. But in summary, that's it. And again, we want to make sure the best care for these patients.
Yeah, well said. And I think we can't emphasize enough making the patients feel safe and confident about what's going to happen. And then honestly, prevention starts then too. How are we going to make sure they don't fall again? What are the things we're going to put in place? So
Definitely.
so important. Some of the only times we're going to have 24/7 touch points with the patient. And we really have so much opportunity in that space to not only leverage what's evidence-based right now, but to continue to optimize this for the future.
Yeah, that is very well said.
Well, excellent. What a great quick session, Megan. I really appreciate your time.
Yeah, thanks so much for joining us today. Hopefully we'll see you next time.
Yep. Take care. Bye-bye.
Bye.